Hello and welcome. My name is Jenny Jimenez, and this is a diabetes self-management education and support program plan for St. Anthony Hospital community called Diabetic Connect. Here is a brief overview of St. Anthony Hospital and the community it serves. The target site would be the Center for Diabetes and Nutrition, Obesity and Metabolism at Little Village. A brief background of the problem. We all know that diabetes is the seventh leading cause of death and costs of an overall $322 billion per year. Here in St. Anthony, there has been an increasing prevalence rate of about 9% from 2009 to 2015, according to the SAHCHNA, affecting mostly African Americans or blacks, followed by Hispanics and Latinos. Assessment has shown that because of the makeup of our community, there's a high rate of overweight and obesity, the ethnicity or race, which is mostly minority, high rate of poverty, and access to care all builds up to the increasing prevalence of diabetes. So another thing that our community has low education proficiency as well as lack of education on the disease. Our community does have a low high school graduate of only about 66.2%. And although key informant interviews believes that education is very important in diabetes self-management, not most of them are aware that we do have an adult program for the community. There's a lot of confusion if the program is ongoing or the program is not going and things like that. We all know that education is a key component in diabetes self-management, incidence and prevalence reduction, as well as prevention and progression of the disease and complications. So what is the problem? Based upon the population assessment process and in collaboration with key stakeholder interview, there is a high prevalence rate of uncontrolled diabetes within our community, as evidenced by ED visits with elevated blood glucose of more than 240 milligrams per DL. The SAH leadership and team hopes to address this burden through the provision of community wellness and clinics, as well as the education since 2003. Currently, the adult DSME/S as a site has limited sustainability capacity, and this could be due to a variety of factors. Number one is through the need for a more strategic DSME/S planning to sustain the program. Use of the planning frameworks as well as conceptual frameworks will have a more rooted plan in carrying out future programs. This could also be related to the absence of a concrete organizational policy, as there is no concrete one available at this time. And going through the next one, which is poor organizational capacity in terms of having enough staffing and resources. Currently, there's only one community health nurse, and she is doing a fantastic job in running the gestational diabetes. However, taking on the adult diabetes program as well would be a lot to do. The ADA ideal group of running a DSME program would be a two healthcare provider, either a registered dietitian or a registered nurse or a program coordinator, as well as the presence of other professional educators, as diabetes is multifactorial and does take a team to take care of one patient. And this could also be due to the high staff turnover rate, which unfortunately we do not have any control. And because of this, it trickles down to the poor program adaptation. It appears that if a staff leaves, the program goes into a halt. And finally, last December, there were inadequate awareness of referrals from the ED staff where participants were supposed to come. For some reason, they were confused if there was a presence of the diabetes program or not, and not most of them were filling up the referral forms and sending it to the site. And lastly, funding. This plan aims to target the SAH site staff, the organization, and ultimately to help the adult patients with type 2 diabetes. To be able to address the program adaptation issue as well as the strategic planning, conceptual frameworks will be used for two phases in carrying this plan. First phase would be Lewin's plan change theory in attempting to change internal organizational structure. Phase 2 would include using Bandura's social cognitive theory, targeting the patients or the participants in changing their habits and their knowledge and their lifestyle and improving their health. As for the plan framework, pre-seed proceed will be used for this by Green and Kruder. The overall program goal is to provide adults with type 2 diabetes in the St. Anthony Hospital community with a sustainable, evidence-based, and effective diabetes self-management education and support program within the site by aligning with the ADA standards, improving organizational capacity, streamlining the referral process, and increasing the St. Anthony Hospital site DSME/S program participation. The next three slides will be objectives. First is the short-term objective. By May, I would like to be able to develop an organizational policy for DSMES and as well as introduce a new electronic health record, which is Chronicles, which is free to use for any ADA certified program. This Chronicles is particular for diabetes self-management education patients, and it's very good in tracking them. Next, in June, is the approval of the organizational policy, approval of the new EHR, and hopefully the development of new and up-to-date curriculum with new instructional materials. By June to July, staff and volunteer recruitment is hopefully would be done. And then in August, about 1 to 2 volunteers is hoping to be recruited. 100% staff will be trained, the site staff, the ones that are recruited. And at the same month, hopefully 80% of ED staff will be aware of the new DSME/S program, wherein they will be able to participate and be proactive in referring patients to the site. By September, it's hoped that 50% of ED staff will submit referrals to the site. And in October of 2017, a pilot program will be launched. Continuing on to short-term objectives, it is hoped that by October, there will be at least a 200% increase in program participants. The last time an adult DSME program was held, there were only 3 successful program participants, and so this time we are hoping for a target of at least 6 every 4-week period. 50% of program participants will have an increase in diabetes knowledge skills, which we will measure pre and post program. And also, 50% of program participants will have an increase in diabetes self-efficacy scores. So this impact objectives more are directed to the program participants themselves. And hopefully at least there will be a 0.5% decrease or improvement in their hemoglobin A1C, which we will be following up at the 3 and 6 month post-program completion. Long-term objectives would be expanding the recruitment of program participants from other St. Anthony Hospital sites or clinics by next year, January 2018. And the next one would be the submission of an annual status report or an ASR to ADA. So the program site has been certified by ADA as a recognized education site. Submitting an ASR annually is a requirement to be able to maintain that certification. Next is that 50% of program participants will have no ED visits following a year of program completion, because we are hoping that with the increased knowledge and self-efficacy, they will be able to maintain their diabetes better, as well as we can connect them to primary care providers and help them with their medications, so there'll be less ED visits. And finally, we'll be able to apply for an ADA recertification by May 15 of 2019 if this is still a goal for the organization. So what is a DSME/S? So this stands for Diabetes Self-Management Education and Support. This is a program that could be given individually or as a group. And this is based on ADA 10 standards, which is all aligned in here. Multiple literature review had shown that providing such programs to a patient or the community has been a cost-effective and cost-efficient way of reducing hospital admissions or readmissions, lowering risk of complication, improving their quality of life, and enhancing their self-efficacy and empowerment. One of the programs that has been very successful in using this is called Project Dulce, that was started in 1997 in San Diego, California, and has been very well renowned all over the United States and has been replicated multiple times. So why do we need to recertify? What is the importance of being recognized by the ADA as an education recognized program? Well, you'll be able to get all of this free DSME and medical nutrition reimbursement guide. So basically, a provider can bill a patient or a participant for every time that they attend the program. There'll be referrals from local ADA offices. You can have access to the claims education materials both in English and Spanish. And this could all be accessed through the Chronicles EHR that's also free of use from the ADA. And then there's just a lot of like free resources that you can use to promote the program using the ADA. So there's two phases of the intervention. Phase one will be looking in first, and this is doing an organizational change. Phase two will be looking out or reaching out, which is the individual or the program participant behavioral change. View of the timeline, as I mentioned earlier, this is more of like a better picture on how we are planning on moving about with this program. Here is a brief overview of the budgeting. I can furnish you with a more concrete budgeting in an Excel format, but just to give you an idea, most of these are in kind. The total for a program plan year, we are at about conservative of like $38,803.46, and most of this really is the community health nurse a salary, as currently she's the only full-time position that we have. I cannot stress to you as much as how cost benefit analysis is on how much a DSME program for a patient can affect not only the individual but also the organization and the community. Say, for example, as mentioned earlier, our target is at least six patients in every completion of a 4-week program. Okay. Um, the cost of each visit is clumped together, meaning they come to the emergency room depending on what their diagnosis is and their level of care that was given. That's how much they're going to get charged. And usually patients with diabetes are at the level 3 or level 4, and they'll be charged about $708 to about $1,394. Mind you, this cost was from last year, so this could have increased. So for about 6 patients, the cost about $4,248, so about $8,364. Medicare usually reimburses at about 80%, and this is how much the hospital could get reimbursed if they have insurance. So that's another thing that we have to consider. So the proposed intervention for the whole program plan, and this is the conservative budgeting, is about $38,803.46, and I divided this into 12 months. So in a monthly, looking at it at a monthly cost is about $3,200. Now, if we deduct this for every month and for every 6 patient visit, we'll be saving at about $1,000, about $5,000. And again, if this patient does not have any insurance, then them bouncing back to the ER is more cost savings that I could calculate as of this time. And again, looking at Medicare reimbursement, you're looking at about $100 per person to about $3,000 per person. So the sustainability capacity has one of the assessment issues that I have found out early on through this planning program. And using the PSAT tool, or the Program Sustainability Assessment tool, I was able to pinpoint out and be able to address some of this sustainability capacity issues moving forward. Of course, first is maintaining the support of stakeholders, internal and externally. We do have a great support from our leadership committee. However, I think that we could have more support from the outside as well, developing great relations regarding what other diabetes education programs the other community also has. Again, building strong environmental support, identifying potential and appropriate decision makers outside of the community. Of course, we do have our program champions here within St. Anthony Hospital, and again, partnering with other potential groups, hopefully with a more concrete program plan following conceptual frameworks and the like, that the program will be more adaptable and will be more flexible in case of like staff turnover rate or a lack of resources. And then of course, we do have a great grant writer who's always looking for grants and funding, but then, we could also start looking for other venues like fundraising projects for just the diabetes program itself. And again, in-kind donations. I do feel that having a concrete program plan, having the support of our leadership and community team, and the enthusiasm of Cindy and the staff, I feel like this program, once we launch, will be very successful. And so, I am planning on getting published on this, or having a poster presentation to share the success. And although right now we are still on the planning program stage, I really have a good feeling because of the strong support that we're getting internally that this is something that we should be looking into. Thank you so much for taking the time and listening to this presentation. It's really brief. However, if you have any more questions, I can give you a full detailed program plan analysis. Below is my email, or you can direct any questions to my great, awesome um, site preceptor, Cindy Magallanes. Again, thank you so much and have a wonderful day.